Thank you everyone for staying, and I know this is going to be a very short talk, so I'm here to discuss vitamin D and the prevention of type 1 diabetes, and I have nothing to disclose. This was funded by the National Institute of Health. By way of background, so this is really a short love story about vitamin D and type 1 diabetes, so I'm just going to go over it in layers, and it's a summary of work we did over the past 5 years, both in Massachusetts and in New York. I think you guys loaded the wrong slide, but anyway, this shows the current studies going on or that have been completed in the area of the disease-modifying therapy in diabetes. So what we know as type 1 diabetes is an autoimmune condition that is marked by hyperglycemia as a result of beta cell destruction of the by autoimmune process. In some situations, we are not able to show evidence of autoimmunity, just like that blue muffin baby in that vignette. But maybe have type 1 diabetes, but you're not going to pick up autoantibodies. So we call that type 1D. So what is the honeymoon period? This is a period of partial remission when, as you make the diagnosis and you begin to treat the patient with insulin, some of the surviving beta cells will recover and they will begin to secrete insulin. And that is important because during that period, you have residual beta cell, you have improved insulin sensitivity, reduced risk for severe hypoglycemia, and all levels of glycemic variability. And it's also an opportunity for investigators to introduce new therapies, diet, and things like vitamin D to help expand the beta cell mass or prolong the partial remission, because it has two important consequences. You reduce the intensity and also the prevalence of long-term complications of diabetes, and that's why everybody is looking at this phase of type 1 diabetes. So there's some controversy about how we define this honeymoon phase. The American Diabetes Association uses what's called a static definition. So the peak level of stimulated C-peptide following a mixed meal tolerance test. But other bodies are now using functional definition called the insulin dose adjusted A1C. And insulin dose adjusted A1C has to be less than 9 for someone to be in remission. And if you're going to use serum C-peptide level, it has to be more than 0.1 nanomole per liter fasting or greater than 0.2 nanomole per liter stimulated. So let's say a few words about C-peptide. It's a very interesting polypeptide actually. It's co-secreted with insulin. It's a 31 amino acid polypeptide. It has much longer half-life than insulin, 31 minutes. Insulin is 4 minutes. So we use it as a marker for insulin production. And one good thing about it is that it doesn't really have any receptors, so it signals through chemokines and intermediary cytokines. The one that's important to us today is this TNF alpha. So we're going to talk more about it as we move along. So we did this study, which I'm going to talk about, but before then, let's talk about vitamin D. Vitamin D is a sunshine vitamin. It's made under our skin. Once we expose ourselves to solar radiation, the UV radiation hits our skin, and then we begin this process called photolysis, where we convert 7-hydroxycholesterol in the skin to free vitamin D, which is unstable. It is then, it undergoes another process because of the heat in the skin. It's called thermal isomerization, and forms vitamin D, which then is transferred to the liver, hydroxylated at the 25 position, and then is stored. So that's the story from our vitamin D. Vitamin D can also be taken by mouth as vitamin D2, which is endocalciferol, or D3, which is cholecalciferol. When the body needs vitamin D activity, it is transferred to the kidneys and then hydroxylated at the 1 position to form calcitriol, or 125 dihydroxy vitamin D. And this is the active form of vitamin D. So I have two questions which I usually ask the fellows. Can hypervitamin D result from excessive sun exposure? So the answer is no, because once the body makes enough, then the rest will be converted into cholesterol, which is restricted. The other question is, does one need to be under the sun for hours and hours to make enough vitamin D? No, because this process called thermal isomerization continues many, many hours after you've left the sun exposure. So no need to stay in the sun forever. Does every child with type 1 diabetes undergo partial remission? In 2016, when we started this study, I didn't know the answer to this question, but now I know. So we did studies with others showing the instance of partial remission. And the one we did in the Boston area, we showed 42.2% of the children with type 1 diabetes having undergone remission. So it's not everywhere that goes through remission. So overall, it's about 50 to 60% of children with newly diagnosed type 1 who will experience remission. And then, so we began this journey in 2017 when we published our first paper in PLOS ONE, where we showed that the peak incidence of partial remission occurs 6 months after the diagnosis of type 1 diabetes. And partial remission is more robust in boys than girls, and then it peters off thereafter. Now, there are factors that will now determine who will not go into remission, so we can pay more attention to those ones, because they are the unlucky ones. So we published this paper showing that 4 clinical factors at the time of diagnosis of type 1 diabetes could tell you who will experience remission or not. These will include acidosis by carb of less than 15, young age, female sex, and presence of multiple diabetes autoantibodies. So is it easy to monitor remission after the diagnosis of type 1 diabetes? Because this formula that we use, which is insulin dose adjusted A1C, which is A1C in percentage plus 4 times total daily dose of insulin, is too long, and it's not easy for a basic clinician to do that in the clinic. So we did a study showing that if you correlate insulin dose adjusted A1C of less than 9 to insulin doses, absolute insulin doses, then if a child is receiving less than 0.3 units per kilogram per day, that child is in remission. So that's an easy way to actually know who is in remission or not. So we had some media coverages in 2017, and then in 2018 we moved from glucose to lipids. We say, can we show that partial remission can affect lipid levels in the near term? So we did a study showing 5 years after the diagnosis of type 1 diabetes, LDL cholesterol is significantly lower in children who underwent remission, even though they are overweight and obese compared to their peers who did not undergo remission. And when they are going through puberty, LDL is significantly lower in those who underwent remission compared to those who did not, telling you that partial remission protects against the deleterious effect of obesity on lipid fidelity. And so by the end of 2018, we had made some conclusions. One, that there's a predictive model for someone who cannot go into remission. There's a way to monitor people who are going through remission. And there's also a consequence for not going into remission, which is early phase dyslipidemia. And that made us think, maybe we should study this in adult patients and see if they have the same phenomenon. We don't know. So we started the study in 2021. And we just want to know whether across the lifespan, is this something that is seen, or is it something that is pediatric specific? So we published a paper in 2021 showing that, yes, adult patients actually have this dichotomy. And we showed this in this 2-dimensional graph, where we use factor analysis, where you bunch up conditions together and assign them a score. And so we showed that those people who remitted looked like the control group of non-diabetics, right? But then those who did not remit looked more like the type 2 people. So this is a lower risk quadrant, and that's a high risk quadrant, showing that type 1 diabetes, even though it's a disease condition, but it has many endotypes, okay? So, and then at that point, I remember giving this lecture in Massachusetts, and I was saying, oh, so what are you gonna do with all this data you collected? I was like, maybe I should, propound a theory at this point. Who doesn't want a theory, right? So I was like, so what I did here was, if you follow what I've discussed so far, so you go from preclinical diabetes, these are the factors that will determine who will go into remission, and those who experience remission have better control. And people have always said it's because of the metabolic memory, that the body remembers all those events at the time of diagnosis, and that's why they are doing very, very, very well. And then those who are unlucky not to experience remission, will again go into poor metabolic control. But before 2022, they say it was because of hyperglycemic memory, right? That the body remember the hyperglycemia at the time of diagnosis of type 1 diabetes, and that's why they go on to have worse outcomes, right? But that could explain only the microvascular complications, due to, glucotoxicity. But it will not explain the macrovascular complications, the large vessel diseases, atheromas, atherosclerosis, and so on and so forth. So that's where my theory of hyperlipidemic memory came into play, because that would explain the microvascular complications. So we published this paper in 2022, and then are there things we can do now to prolong that partial clinical remission? So we come back to vitamin D again. So we conducted this randomized control trial of vitamin D in patients with newly diagnosed type 1 diabetes. We enrolled 48 children, and then we randomized 36 of them. 18 of them received high-dose egocalciferol, 50,000 international units every week for 2 months, and then every other week for 10 months. And the other 18 received placebo. We followed them out for 1 year, and we analyzed our data using intent to treat principle. So we showed that those who received vitamin D had higher levels of 25 fatty vitamin D. That's what you need to show. And then we showed that those who received vitamin D had significantly lower levels of TNF-alpha, tumor necrosis factor alpha, which I talked about a few slides back, showing that vitamin D has anti-inflammatory properties. Let me go through this. So this is a better reflection of our result than the ones we published, because the media houses know how to present this. So this shows blunting of the temporal rise in hemoglobin A1C and insulin dose adjusted A1C for the vitamin D group compared to the placebo arm, right? So that's a positive metabolic outcome. So we published this in the Journal of the Endocrine Society. It was well received and all that. We presented it at the ADA meeting in New York. Yeah, we got a prize. That's my team. Some of them are here. That's at the JDRF. So then people were emailing me and saying, okay, so how do we dose this newly diagnosed patient with vitamin D? What do we do and all that? So, after I got tired of all that, I said, let me write a review article just outlining what to do. So I published this guidance for high-dose vitamin D for prolonging the partial clinical remission phase in children with type 1 diabetes. This is the summary table. So when a child is diagnosed with type 1 diabetes, check vitamin D. If it is greater or equal to 30, monitor the serum vitamin D. Now, if it drops to less than 30, you can supplement with egocalciferol or cholecalciferol to maintain the level between 30 and 60. If it's less than 30, initiate vitamin D supplementation with either of the analogs, and then maintain serum level between 30 and 60. Very simple. And so all these things happen. So in 2014, we said, now, let's move from glycemic endpoints to what is going on in the beta cell, because that's really what you need to touch to prove that you have done something. So we go back to our friend C-peptide, okay? So basically you have this pro-insulin polypeptide that contains insulin and C-peptide that is broken up into insulin and C-peptide. So what we showed was vitamin D actually improves the conversion of pro-insulin to insulin and C-peptide. It could be through the activity of all these pro-convertases, but it does it. That's the mechanism of action. And this is the holy grail in disease-modifying therapy research. You have to show this thing called PIC ratio reduction, because the lower the PIC ratio, the lower the beta cell endoplasmic reticulum stress, and then the better the residual beta function, and the healthier the beta cells are. So we showed that even though the placebo group started at a huge advantage, lower PIC, they lost that advantage over time. Look at vitamin D. They started at a huge disadvantage, but they kept that PIC ratio low. And that's why we were able to show a significant difference at the end of the study. And this was the reason why my friend here said, so he called me the day it was published. I said, how did you know this was published? And then the other thing we found was that those who received vitamin D had a slower decline in their area under the curve of C-peptide compared to the placebo arm, where it decreased quickly. Telling you that vitamin D is protecting the beta cells through various mechanisms, including reduction in inflammation, making these beta cells healthier and producing more C-peptide and insulin. So these are the diagrams in the publication. And there's the paper. And of course, Medstead carried it in their feature article, Endocrine Society, that's me, so, and the news with our patient and the mother. And so, has this actually impacted patients? Yes. So at Cohen's, we use this knowledge to, offer vitamin D treatment to our newly diagnosed patients. They can say yes or no, but we track them as we see them in the clinic. And then last year, we were invited to the ADA. This was featured at the Thought Leader Series. And, in other places, I received this card a few years ago from a parent. They live in Georgia. I've never met them, but they're always calling me every 6 months to check in, and their kid is still in honeymoon after 2 years of high-dose vitamin D. So we're thinking of writing up that case. So I wanted to put this up because we have some people who don't like vitamin D, right? So this recent study was published on March 10th, showing that vitamin D actually has impact in disease activity of multiple sclerosis. High dose. So remember, it's high dose that works, not the low dose thing they're doing. And then, if you're an endocrinologist, you may know about the recent Endocrine Society guideline on vitamin D. Some of us did not like it, so we now have an avenue through Frontiers for people to, submit papers either for or against. So I'm one of the editors of that research topic, and we're accepting papers. It takes a whole village to conduct these studies. So many thanks to all these people, NIH for supporting our study, and all the media houses that covered our research, and my chair, and all the children that took part in the research. Thank you, everyone.